So let's go ahead and get started. Well, welcome to tonight's webinar. We're going to be talking about what may appear to be the most boring part of the blood test, but I can assure you it is absolutely rich with clinical information, and you just learn so much from this. Now, I believe this is probably the top ordered blood test, of all the blood tests. I think this is the number one. If it's not, it's number two. CBC would be number one, but I think CMP is the number one. And its complete metabolic profile. You look at the little bit about what the liver's doing. You can see what the kidney's doing. Acid-base balance, that's a very important issue. Look at basic things like calcium, protein, and so on and so forth. So let's look at this not just from a disease perspective, but I want to talk about from more of a functional look. So let me get my screen right here. Okay. All right. As we talk about when we read blood, this is one of the things I really want to get across. It's all about patterns. Everything is about patterns. So when we look at a pattern, in other words, we don't just look at, aha, there is the glucose, so I know what it means. Or there is the sodium, it's high, it's low, it must mean this. Or we don't look at it that way. We always look at it from the standpoint, we start with an observation. Somebody walks in the door and you look at them. And I'll give you an example. Somebody comes in and you can see right away that their waist is bigger than their hips. They're shaped like an apple. You can know already before you've done anything that they're going to have a level of insulin resistance. And then you do a history and you find out that sure enough, after they eat the noontime meal, they get sleepy. And that's also consistent with insulin resistance. Then you do an exam and you might see some skin tags or acanthos nigricans, fat in the tricep compartment. You might see some things like that give you an indication, or that central obesity gives you an indication of insulin resistance. And then you do the labs, and it's not a surprise when you see things like the enzymes found in the liver, either up or down, cholesterol is off, blood sugar, glucose is high, because that would fit the pattern. So in other words, we don't, and I know some people do this in functional medicine, and God bless all the people out there working in functional medicine. So don't hear me, putting too much critique on it. But let me just say this, that you can find yourself in error if you just kind of skip past the history and kind of skip past the exam and you nod off during that part, but you just wait to get the blood, and because that's the cool part, and then you just come up with these ideas that you read from the blood. That you're going to really be in error if you do it that way. So I always want to encourage everyone to look for patterns. All right, so there's a clinical decision-making tree. We've talked about this. I'm only going to briefly talk about this, but I want to talk about it in light of the developing patterns. So when we look at it, I've highlighted some things. So somebody comes in, and on their intake form right here, their history before the patient's seen, you're going to see things. Let's talk about blood sugar a while ago. They may say things like they get irritable if they don't have food, if they get hungry, maybe when they stand up, they get dizzy. They easily kind of emotionally lability problems, for instance. They have a hard time, with emotional distress. These kind of things would kind of lead you to possibility of low blood sugar or reactive hypoglycemia. And then you would take and see if the rest of the patterns fit. Observations prior to the meeting, we just talked about those with the insulin resistance. Talking the physical exam. When we do the physical exam, there's certain parts of our physical exam that we're going to do no matter what. Like, for instance, every patient I have, even my babies, I'll do some level of a cranial nerve exam. I don't do all 12 of them because you don't need to in a regular basis. There's always a time that you can say that you would want to run any one of them, but I generally will run cranial nerve 3, 5, 7, 9, 10, and 12. Those are the cranial nerves. And actually, the way I do them in order, I'll go 12, then 9, 10, 7, 5, 3, because it just goes in order that way. But that's something I'll always do. I always like to look in the ears. I always like to do, look at the hands, measure temperatures. I like to do things like that. You look at the vitals. But when you see a pattern develop from the history, you might do something in your exam that's even above and beyond what you usually do. Give an example. I'm always looking at the face to see the lateral third of the eyebrows. I want to see scalloping on the tongue. I want to see if they have coarse hair. And if you know where I'm going here, we're thinking about a low functioning thyroid. Now, if I see those things, or somebody says in their history, man, I eat like a bird, I exercise, and I can't lose weight, and I have 10 pounds extra, and I'm not really changed anything I've done. I'm actually working at it harder. That would prompt me to go a little further in my physical exam, make sure that I'm doing the Achilles heel reflex, and I'm doing some other things that are associated with thyroid. So there's a basic examination I'm going to do across the board, but based upon patterns that are emerging from my history, I may add more to that physical exam. And then I'm going to order labs. There are certain labs that I'm going to run on nearly everybody. And so everybody comes in, I don't, because I do upper cervical work, there are times here and there, very few, that somebody will come in that I don't get blood work. I'm just checking them. But most usually, I don't even know what it is. It's got to be over 90% of the time. I'm getting, blood work. I'm getting urinalysis. I'm getting other labs because from my work, I can't tell what's going on with somebody unless I have the labs. But there's always a certain set of labs I'm going to do. But go back to my pattern. Somebody comes in, the hip is bigger than the waist. Their blood pressure is a little bit up. They get tired after meals. They have acanthus nigricans. This is all a pattern of insulin resistance. Well, I'm not only going to do my regular kind of standard blood works, it's what I would call a comprehensive screen where we look at all those things, but I'm also going to look at the fasting insulin, a C-peptide. I'm going to measure the HOMA-IR score. I might do a glycomark. I might do things like that because that pattern has emerged to let me know that now that could be significant. Now, once I get my pattern, and I might find 3 or 4 patterns going on in a given patient. One pattern might be they have insulin resistance. Another pattern might have emerged that they have a chronic infection. Another pattern that emerged, they may have a sludgy bile. They might have something that make me think that the hepatobiliary tree is not functioning properly. So there would be my 3 patterns. Now, when I start to go to a protocol, now I'm going to develop a strategy based on the patterns, and I'll take a priority list. Infections always get the top priority unless they're chronic. If they're acute, they always get top priority. But then I'll also need to address insulin resistance, and I may, at the first swath, go ahead and start working on the hepatobiliary system, or I might just say, hey, you know what? If we can get the insulin resistance under control, get the infection under control, I bet that hepatobiliary system will start working just fine, and I would skip that out. That's all a clinical judgment, and there's no wrong answer to that. There's just, this is the clinical decision-making tree, and this is the process. So let's get on with the presentation with the specific analytes. All right, so when we see this, I'm gonna just get this out right here. Good. All right, so glucose, it's the end product of carbohydrate metabolism. It's influenced by hormonal and liver function. Let's talk about that just a little bit. If you think about it, the liver is the great modulator of blood sugar. In general, we can make this statement. As sugar begins to rise in the blood, your liver will begin to store it in glycogen storage. When sugar starts to drop, then the liver in general will release that. Of course, this is based on hormones. What does insulin do? Insulin's job is to pack the sugar into the liver so you can store it. That would be what the insulin does. So when sugar starts going up, insulin's released, and then we store it. When sugar starts to go down in the blood because you burn it up, then glucagon is released from the pancreas, and glucagon's job is to open that up and release the stored sugar in the liver. So that's the reason why when somebody has any blood sugar issue, the first place we look is the liver. Is that the only thing that can cause blood sugar dysregulation? Absolutely not, but it is the most common. So you want to look, and you want to look for emerging patterns. Do they have a congested liver? Do they have an inflamed liver? Is there something going on with the liver that's causing that? All right, so more insulin is not the answer. Okay, so let's look at this. It's really kind of interesting, but when you look at glucose, there's a very tight range. Fasting glucose, perfect, is 85. Once you hit 90 or you hit 80, once you hit 90 and above, you've already lost a lot of support system to keep it perfect. So the horse has already left the barn by the time you have a fasting sugar of 90. And I know that sounds fairly radical, but it's really not. Your body's going to fight like crazy to keep that blood sugar at 85 as a fasting. And once it deviates from that, if you're at 86, 87, 88, no problem. But you get up to 90, 91, 92, yeah, it's not going to cause you a great deal of problem that your blood sugar is too high. That's not the issue. But what it is, it means you're losing some of your ability to regulate sugar normally. And blood sugar is very important for your overall health. Once it starts dripping below 80, now you're starting to lose storage capability. Your liver's not able to handle and keep up. So let's look at this. I'm going to draw a drawing here. Here is the liver. So we only have about 4 to 5 grams of glucose in our blood at any given time. That's about a teaspoon. That's not very much sugar. From your nose to your toes, or from your head to your toes, whichever, you have only about a teaspoon of glucose in your blood. Now, diabetes, prediabetes, and diabetes is a storage disease. When you lose capacity to store sugar, and the 3 primary areas you store sugar is the liver, the muscles, and the fat cells. And you could even say in the blood it's triglycerides. So there's 4 main areas that you're storing sugar. And when you get insulin resistant and you can't store the sugar anymore as well, then your sugar begins to rise. And when you hit 6 grams, that is when you actually become a diabetic. Well, here's something most people would be surprised about, that once you hit the 8 grams in your blood, sugar in your blood, you could go into a coma. Not everybody goes into a coma with 8 grams, but you certainly could go into a coma if your blood sugar goes above 8. You could go into a coma if your blood sugar is lower than 2. Now, the point I want to make here is you don't have a lot of people go into comas, of course, but there is so many redundant systems in your body that's going to make sure that your sugar stays in this sweet spot. That's the reason why I say once you've raised up over 90, you've already lost some of that support and you're not doing it as well as you need to. Now let's look at this. Don't snooze off when you look at this. It's a pretty straightforward drawing or a diagram. So this is food that comes in after you eat. It goes into your liver as G6P. That G6P, let's back up. We talked about 4 to 5 grams being in the blood. If you go all the way to 8 grams, you go to a coma. The average meal is about 75 grams of glucose, carbs. So 75 grams cannot go straight into the blood. If it did, you would go into a coma. So what happens is when you eat the food, it goes to G6P first. Then only about, depending on how much sugar you've eaten in that meal, only 2, 3%, maybe 5%, depending on how much carbohydrates you've eaten, only about 2 to 3, 4%, maybe even 1% is going to actually go to the blood. The rest of it's going to go down this pathway and it's going to get stored as glycogen. And so what's supposed to happen is this, is that when you eat, whoops, let me do this again. Okay, so 85 is perfect sugar. So when you eat, sugar goes up, and because a little bit of it got released, and then you burn that sugar up, and then you let loose of those glycogen stores, and it comes back. And about this time, you get hungry again, and that's a normal blood sugar swing. And we need to be really tight in here. Okay. One more thing I want to make a comment about that's very important is this: is that your brain, if you're not on a ketogenic diet, your brain only burns glucose and oxygen as fuel. So your body can burn fat, protein, sugar, right? But your brain, unless you're on a ketogenic diet, only burns glucose. So your brain, in order for it to be healthy, has to have a reliable source of fuel. So when your sugar starts doing wonky things, it's too high, it's too low, it's bad for the brain health. Keep in mind, the brain is 90% of the energy of the brain is all consumed in regulating the autonomic nervous system. The autonomic nervous system is that system that allows us to adapt to the environment. It's that system that makes everything work well. right? That we can adapt and thrive and have vitality. When you mess with the fuel to the brain, you're going to mess largely with your capacity to regulate this autonomic nervous system. That's the reason why when people have low blood sugar, they can have more emotional lability because they're not as emotionally stable. Why? Because the brain doesn't have fuel. The brain doesn't have fuel, right? I like to say the brain is like mama. If mama ain't happy, nobody happy. Same thing with the brain. All right, so let's move forward and look at some patterns. So reactive hypoglycemics, I want to make a distinction here. Reactive hypoglycemia can be a completely clinical diagnosis, meaning this, that when you have reactive hypoglycemia, you may not see any labs. Your blood sugar may be perfect 85, and you might not see one lab that tells you that, aha, that's reactive hypoglycemia. There's some rule-in labs that you can say, yeah, that's reactive hypoglycemia more than likely, but you don't always see it. But I will tell you this, if somebody gets irritable, if meals are missed, and eating release fatigue, or they get shaky, jittery tremors, any one of those three is going to be a pretty good indication clinically that they at the very least have a functional reactive hypoglycemia, and they're going to need to be taken care of accordingly, because that's a pattern you're going to have to deal with. All right, so there's a difference between dealing with people with reactive hypoglycemia and having insulin resistance, so you want to make sure that you know that. So these are some of the signs and symptoms that people can have when they have reactive hypoglycemia. The three that I pointed out are just probably the three most hardcore. If you see that, any one of those is kind of a slam dunk to let you know there you're probably dealing with reactive hypoglycemia at some level. Physical exam. Well, sometimes what will happen is this. Here is the brain, the nose, and the mouth. If you have somebody that's dropping in glucose and they're doing this day in and day out, here's a reaction that can happen. Here's a kidney. Above the kidneys, you have the adrenals. Adrenals aren't really that big. I just did it that way because writing adrenals there. Adrenals kick out cortisol. They also kick out epinephrine and cortisol. Cortisol is the major modulator of three very important functions. Cortisol is the modulator of blood sugar. It's the modulator of blood pressure, and it's the modulator of the immune system. So when you release cortisol into the system, it's going to raise the blood sugar. If you release cortisol in the system, it's going to raise blood pressure. So think about this. When you're under stress, what is the innate thing your body does? It releases cortisol so you can get energy for the brain. Because what does raised blood sugar and what does raised blood pressure do? It gets sugar and oxygen to the brain. And so when you're under stress, what does your body do? Cranks up that energy for the brain so you can deal with the stress. It's a pretty cool innate mechanism. It's also going to dumb down or it's going to inhibit the immune system. Because when you're in a fight or flight mode and you're needing energy right now, you don't need to be fighting off a virus or fighting off a bacteria. You need to be all hands on deck and getting through whatever the stress is. Now, what can happen though when somebody has chronic low blood sugar? That says, I don't mean when I have chronic reactive hypoglycemia that's crashing all the time, then the pituitary is constantly sending out ACTH, the alarm to the adrenals, get got cortisol, and you're doing this loop over and over and over. Well, what happens over time? You lose your ability to make and release cortisol. As you reduce your ability to make cortisol, guess what wanes down? You're right. It is the blood pressure. Why? Because cortisol is a modulator of blood pressure. And if you don't make enough cortisol, you're going to have low blood pressure. So if you see somebody, you show me somebody has chronically low blood sugar or blood pressure, and I'll show you somebody that's struggling with low blood sugar. So we have to work on this. Orthostatic hypotension. Somebody stands up, they get dizzy. Well, there's another mechanism that happens. In the top of the midbrain, you have hardwired. Hardwired means it's not Wi-Fi. You got a monosynaptic connection between the midbrain to the middle part of the adrenals to kick out epinephrine, adrenaline. So when you stand up, your brainstem, vestibular system, will recognize that you just stood up. And when it recognizes you just stood up, it sends a message immediately to the adrenals to kick out epinephrine, so we can very quickly, within just a moment's time, have at least a 10 millimeter rise in systolic pressure. So when you stand up, your vestibular system knows it. It sends a message down to the adrenals, and the adrenals kick out epinephrine, and then you get higher blood pressure. Why do you do that? Because if you stood up and you didn't do that, you don't get enough blood to the brain, and guess what happens? You have orthostatic hypertension. You actually get dizzy when you stand up. Okay, and cranial nerve deficits. Let me talk a little bit about the cranial nerve deficit. This is not specific for hypoglycemia, but when you have a hypoglycemic, this can fit in the pattern. This is cranial nerve 12. What I want you to see is the fasciculation of that tongue. You see how this movement, not the gross movement, but the overall movement. If you look at that, look when he sticks it out, he'll stick it out here in just a second. And look, it looks like there's just little worms in there. You see that? That's the fasciculation, and it's not specific for reactive hypoglycemia, but when you have a sugar or a fuel problem in the brain because you are a reactive hypoglycemic, that's one of the things that you can see. So hypoglycemia has an effect on the autonomic nervous system for this very reason that I've already outlined. And here's the adrenals. The adrenals, think about this. The adrenals are your sympathetic nervous system in your body. So cortisol, what does it do? It makes you move. What does epinephrine do? Adrenaline makes you move. So that's how we do it. It gets fuel to the brain so we can move. That's what it's all about, right? So what is the sympathetic nervous system? It's our movement system. So when we're constantly dinging this mechanism because of low blood sugar, what we do is this in so many cases. Here's the sympathetic nervous system here. Here's the parasympathetic nervous system here, right? This is called the rest and the digest and the repair mode, while this is called the fight and flight mode, right? So we like to live in the middle here at this nice little balance. Sometimes we need to rest and digest. Sometimes we need to move our bodies more, or in the more extreme, fight or flight. When you continue to ding this thing with the sugar, what will happen is you will move yourself more towards this sympathetic side, and you'll become more sympathetic dominant. And you'll have a weaker vagal system, a weaker digestive system, all kinds of things that happen as a result. So this would be, if you see the low blood sugar pattern emerge, one of the things that you can do is measure the temperature there, and versus the wrist, you shouldn't be over 2 degrees difference. If you are, that means you have less blood supply in the hands. And the reason why that happens, let me just finish this up. Okay, so the reason why we put that out there is because if you have a difference in temperature from here to here, that means you have less blood supply here. It's probably not cardiovascular disease, but when you're in sympathetic dominance, you're going to have your blood's going to go to the big muscles in your body so you can fight or flight and go to the brain, and it's going to leave the hands. It's going to leave the feet. That's why you get cold hands and cold feet. You'll see these, spots on the fingernail, somebody's sympathetic dominant. And a lot of times that has to do, look and see if they're reactive hypoglycemic, see if it fits the pattern. We're always banging our fingers on everything, and they should heal and repair. But if you see white spots on people's fingernails, it's generally because there's not enough blood supply in there to heal that up, and it's usually from a sympathetic dominance. Keep in mind, look for patterns. Okay, common causes for reactive hypoglycemia. The most common is the liver congestion. I don't know what the percentage is, but probably 70–80% of these are somewhere in that area are going to be liver congestion. There's going to be cellular valor, it could be other issues, which I'm not going to cover here because it's too broad of a subject. All right, so labs to consider for reactive hypoglycemia. If you see the reactive hypoglycemia, if you have a lab, a lactate dehydrogenase lab lower than 140, then that's a good sign they have reactive hypoglycemia. There's a caveat to that. If you put somebody on a low-carb diet, or when they come in, they've been eating a low-carb diet, then they very likely can be low in lactate dehydrogenase. Remember that sugar goes into the cell, it gets converted into energy. Part of the process is when pyruvate is converted to lactate, and you need that enzyme called lactate dehydrogenase. If you don't have enough sugar going into the cell, that will go low. Keep in mind, if you're not eating sugar, then that's going to have a problem. You're going to see that. Okay, so I'm going to move along here. BUN, LT, we're going to talk about those in a little bit. You get a hemoglobin A1C lower than 5.2. There's one last thing I want to say about this. If your sugar is lower than 80, what that means is this. It means that when you go to sleep at night, you have a whole bunch of sugar that's stored in your hepatocytes. And as you sleep at night, that sugar storage is supposed to release that just a little bit of time, a little bit of time. When you wake up in the morning, cortisol is released. It's just wake up hormone, and that makes your sugar go up because remember, it modulates it. Well, here's what happens. You lose about 60% normally. About 60% of your sugar storage in your liver, you should go through that through the night, and then you build it up through the day. But when somebody's struggling with blood sugar through the day, they can't keep up with the demand, and they just simply cannot have enough sugar through the night to keep them going well. And these people a lot of times will wake up at 3 o'clock in the morning. Why? Because their sugar goes so low, they release cortisol and epinephrine in order to get sugar right away because the brain wants the sugar. And when it does it, guess what? That's a wake up hormone, so it wakes them up. So just some care options for liver congestion that has to do with reactive hypoglycemia. Diets void of grains, white flour, white sugar, high fructose corn syrup, honey. Honey, be careful. People eating honey, they're like, I don't eat anything sugar, but I eat, tons of honey. You're eating a lot of sugar if you eat honey. Okay, so liver detox consistent of like protein powder. You can use amino acids, enzymes, HCl, L-glutamine. There's a lot of things you can do for that. Make sure they're eating a protein breakfast. Make sure they eat snacks in between meals. Always a protein snack. Remember, the faster the sugar hits the blood, the faster they're going to have a problem because it's going to cause sugar spikes and you end up with sugar crashes. All right, so additional support. If you have somebody that's having a lot of problems with blood sugar, then go ahead and support those adrenals. Use an adrenal glandular, maybe some Celtic sea salt, Epsom salt baths. Magnesium is a wonderful mineral to balance out the sympathetic nervous system. Gargling and vagal activation, because the vagus nerve is a very powerful nerve, the most powerful nerve in the body to help balance the autonomic nervous system. So this will all work together in helping you regulate that blood sugar. Keep in mind, adrenal dysfunction and reactive hypoglycemia go together. You cannot have one without the other. You show me a reactive hypoglycemic and I'll show you adrenal dysfunction. You show me adrenal dysfunction and I will show you somebody has at least blood sugar dysregulation problems. All right, so glucose. Type 1, of course, that's an autoimmune. We're going to talk about that. I mean, it's an autoimmune. If it's, the blood sugar's high. Once your blood sugar goes over 90, now we're starting to have problems. Now, advanced glycation end products and vascular inflammation just shows that one of the things that happens is you have to get rid of sugar. So when sugar's floating around in the blood, we can only stand about, 500 to 600 grams of sugar in our body at any given time. That's all we can stand. That's all we can do. We only have 4 to 5 grams in the blood, but we can only do about 500, 600 grams. So when that starts going up, what do? Well, we get these proteins. These proteins are made up of, chains of amino acids, and you get so high of glucose in the blood, what happens is the glucose begins to glam on to those proteins floating in the blood. Well, the problem with that is your white blood cells will now look at that protein and it doesn't look exactly right. It looks different because it's glycosylated. Now that it's glycosylated, now your immune system reacts to it and creates a lot of inflammation. A lot of damage happens with high blood sugar. One of the things that we've done that's kind of led to this, different story for a different day, but we built this pyramid. It started back in 1977 with a select Senate committee, maybe 78, when they decided that we were eating way too much fat and not enough grains. So we started eating more grains. They started subsidizing it, and it became a lot cheaper. And so now, our diet has a lot of, too many carbs in it, and now that has led to a whole lot of problems. This is an interesting one. Familial longevity is marked by enhanced insulin sensitivity. Watch this. Glucose disposal rate. That's what that is. Glucose disposal rate. Glucose disposal rate was significantly correlated with the mean age of death of the parents. In conclusion, offspring with long-lived siblings, basically what they found out is this, is that they studied people who are 100 years old, and what they found is the better the insulin sensitivity was correlated with them living that long. So blood sugar regulation, if you want to, you're going to have a hard time finding somebody that's 100 years old that did not throughout their lifetime have good blood sugar regulation. So some people don't want to live to be 100. That's fine. But if you want to live healthy and well, you got to make sure you have good blood sugar, because that statistically will make you die earlier and make you die of problems and have problems along the way. So here's the next pattern we want to talk about. That's the reason why I take so much time on this glucose. These are the patterns for insulin resistance. Fatigue after meals. When somebody shows that, particularly after the noontime meals, that is a good clinical indication of insulin resistance. Or must have sweets after meals. Their waist is bigger than their hips. Physical exam. Here are the skin tags. You see skin tags on the neck and the axilla. These are signs of insulin resistance. You can even see this on kids, because kids through epigenetics can be insulin resistant. Acanthos nigricans, you'll see that in the underarm, or you see that back. As you check people, you'll start seeing these patterns emerge. That's in the axilla. This fat gathers in the tricep compartments. It's also insulin resistance. That's central obesity. If you have central obesity like that, this is an estrogen factory for this guy, unfortunately, but it is also a sign of insulin resistance. Because guess what? If you're insulin resistant, guess what happens? If you're a man and you're insulin resistant, you will convert more of your testosterone into estrogen than they're really healthy for you. So if somebody comes in, you see them and they're shaped like an apple, not like a pear. This is a insulin resistance. This is a metabolic syndrome look. This right here is generally estrogen, can be estrogen dominance. You just have to see if the patterns fit. You don't just look at something like that. You don't look at somebody, a lady who has the shape like a pear, or a guy, and say, oh, you have, estrogen dominance. You do your other patterns to see if it fits, but that is a clue. Okay, so lab findings. Here's some labs. This is a really good lab that you want to look at. If somebody has glucose that's over 90, when you want to look at your patterns, look at the triglyceride to HDL ratio. Keep in mind, when you are insulin resistant, what will happen is you can't get sugar into the cells very well, so you start pushing it into the liver as fat, and you develop a fatty liver. And when you develop a fatty liver, actually what you start doing is you start dropping your HDL. Now you're still trying to figure out how to store more of the sugar, because remember, we're trying as hard as we can to keep 4 to 5 grams because the body works best here. So if you're insulin resistant and you can't get the sugar into the cell, then you're pushing it into the liver as fat. You get a fatty liver, non-alcoholic fatty liver disease. And then the next thing is you start trying to store this sugar in the blood in the form of triglycerides. So you have a double whammy. In other words, triglycerides go up, right? And HDL goes down. So at the end of the day, when the triglyceride to HDL ratio is above 3, it's a really good indication of insulin resistance. So you're going to find that pattern. If somebody has a blood sugar of 90 or 95, and they have a triglyceride to HDL ratio over 3, then that tells me that, let's say that the blood sugar fasting was 90. If the triglyceride to HDL ratio is above 3, it's a really good indication that they probably have worse blood sugar problems than what it states as 90. There's probably more insulin resistance going on than we can see from just looking at that. That's the beauty of looking at patterns. Cholesterol to HDL ratio should be 2 to 1. So if you have somebody has, let's say, cholesterol at 180 and they have triglycerides at 170, that's also a good indicator. It's not as strong as the triglyceride to HDL ratio, but it still is important. If your enzymes, we'll talk about that in a little bit. HOMA-IR score. If somebody has the history and they have the physical exam that shows insulin resistance, then I am going to order a fasting insulin along with the fasting glucose. Here's what you do. You take glucose, whoops, I'm missing my ink here. You take glucose times insulin, and you divide that by 405. 405 is a constant because it's not enough just to know that for instance, your glucose is 95. You need to know how much insulin did it take to hold the glucose at that level. How much insulin did it take? So ideally, you want your fasting insulin to be 4.5 or lower. Okay. So, but anyway, you multiply these two and you divide it by 405, and you want that number to be 1.0 or less. Average in the United States is 1.7. Whoops, let me get my ink back. Average in the United States is 1.7. Once the HOMA-IR score hits 2.6 or above, that person, I don't care what the fasting glucose level is, if they're at 2.6 or above, they're really approaching diabetes at a pretty rapid rate because their insulin resistance is really getting to a significant level. Now, C-peptide, if you see an elevated glucose, C-peptide is something good you want to see, somewhere between about 1 to 2.5. Once it goes over 2.5, it's a sign of insulin resistance. Now, C-peptide has a little bit of an action like insulin, but it's made out of the same place in the pancreas. So your beta cells are actually where you make your insulin, but those beta cells, you also make C-peptide. When you measure C-peptide, it's a more stable marker to let us know the health of the beta cells. So if somebody comes out and let's say that their C-peptide is 4.0, then we know two things, it's good and bad. It's bad because the pancreas is really working way too hard, but the good news is it still can work that hard. In this case, and their blood sugar is going to turn around faster because they have a relatively healthy pancreas. Take another case, somebody comes in, they have a high blood sugar and their C-peptide is like 1.0 or 0.5. This person's going to have a harder time responding and reversing the diabetes or reversing the high blood sugar. Why? Because the pancreas is not healthy. It's not as healthy. It's just going to take more time. Can they reverse? Yes, they can, but it's just going to take more time. Hemoglobin A1C, of course, we want to see that about 5.5 is perfect. Clinically, if it's 5.7 to 6.5, it is pre-diabetic, and anything above, you have a problem. Anytime it gets over 7.5, you're at risk of neuropathies. I find it funny. I've seen this happen more than once, that a patient will come in and they'll say, well, my medical doctor says that as long as my hemoglobin A1C is under 7, he's happy or she's happy. I'm like, dude, that is way too high. You're going to die earlier than you should with problems along the way if you keep that mentality. You can't do that. But what can we do? Well, we got to go through the mechanisms, find patterns that are going on, build a strategy, and make sure our strategy is working by re-examination and re-labs. Let's look at a few of these. Hyperglycemia. Oh, okay, these labs. Okay, so let's look at a couple of cases right here. Here's the glucose at 96. Look at this. I want to show you something here. The glucose was 96, but they had all of the patterns of insulin resistance. So what did I do? I actually went ahead and ran their insulin. Now I will tell you that is off the charts, 32.5. And C-peptide, look at that. We usually never see C-peptide over 4.5. That's 8.36. I have to say that's the highest one I've seen, I believe. That means that pancreas is just working as hard as it can, to make things work. It's just barely surviving. It's not making it. They're headed for a crash. So if you take the HOMA-IR score, and I actually did this before, and you take the 96, multiply that times 32.5, and you divide that by 405, and they have a whopping 7.7. Now that was the end, the 1st of September. Now, at the 1st of January, which is about 4 months later, we did another test on them. And one of the things that we saw on this is this. Look at this HDL, cholesterol HDL ratio, like that. Look at the HDL, it's sitting at 33. The triglycerides 279. Now let's look at this and see what happened. Now the triglycerides were 279. They went to 157. The HDL was 33 to whatever that was, 269, whatever it is. But you can see our triglyceride HDL ratio got a lot better, right? And so did our total cholesterol to HDL ratio. Now look at this. Glucose is 83. insulin is now down to 13.2. So if you take what's my number here? If you take 83 and you multiply times 13.2 and divide that by 405, then you're going to come up with 2.7. Now, if I saw that right offhand, I'd be like, man, your home IR score is too high. But this was 4 months, and they went from 7.7 to 2.7. This is a big congratulation on this person. Now, this C-reactive protein is up because now the person has a bladder infection. That's a whole different story for a different day. All right, I'm looking at my time, and I can see definitely I'm not going to get all the way through this, so I'm going to have to do a part 1 and part 2. That's okay. I want to make sure we get this good information across. All right, so here's another one. This is a 48-year-old male. If you see, his glucose is at 83. His hemoglobin A1C is at 6. Well, how could that be? Well, when he first came in, he was already trying to go low carb. So his hemoglobin A1C is in pre-diabetic, but his fasting sugar is 83, right? So then, and also his insulin is 12.2. So I measured his home IR score, and we did the 83 times 12.2. We divide that by 405, and we come up with 2.5. So he's still higher than he should be. He's not as bad as the first lady. So what happened afterwards? Glucose at 78, which is actually a little low. Hemoglobin A1C after 3 months gone to 5.6, is getting very good. And his insulin now is 5.8. So we take 78 times 5.8, and then we divide that by 405, and we come up with 1.1. So he's doing much better on that. This is how you keep score. So what did we do with this patient? Really a lot of things that I'm going to suggest you do with insulin resistance. Number 1, low carb diet. You must have a low carb diet in order to combat insulin resistance. Because here's what happens. If you're eating carbs and you have insulin resistance, you are just feeding the fire. There's going to be 4 main reasons for people to be insulin resistant. One is there is a genetic component. That's not the full answer, because if you have the genes for it, it means that you just have to work harder. That's all. Number 2, just eating too many carbs, not now, but throughout a lifetime. Number 3, they can have inflammation, like a chronic infection, food sensitivity, something like that. And number 4, microbiome. If your microbiome isn't balanced good, you don't have good diversity, it can lead to poor signaling of the insulin, and we can have insulin resistance. So these are the 4 things. When you see the pattern of insulin resistance emerge, then you want to look and see which of these patterns, which pattern or patterns fits for that patient. Maybe they have inflammation, maybe they have a poor microbiome, and maybe they're eating too many carbs, and maybe their mom and dad both all had diabetes, so they have all 4. So you have to work on all 4 to support those for a strategy. All right, so liver support, moderate protein, increased fiber, these are the things. And we've talked about, insulin resistance things before. Okay, so Dr. Annette, what I'm going to do at this point is ask if there are any questions before I move on to BUN and creatinine patterns.
There are a couple of questions.
Okay, go ahead.
So one of them is, I have seen many blood pressures that don't increase with standing, and sometimes they go lower. However, right. I've not had many patients complain of dizziness when this happens. Does it make a difference if they don't complain about dizziness?
No, because you have an objective test that shows you it's happening, but it may not be happening to the degree that's causing them problems, because when they're lifting up, when they're standing up, the epinephrine is not being released. And we can tell that because the blood pressure is not, elevating. Keep in mind, and I don't know that you're doing this, I don't know how you're doing it, but just for everybody else listening, you want to make sure that you take the blood pressure, then you completely take the cuff back off, you put it back on, you puff it up, and then you have them stand, and then you listen. So that's kind of the mechanism that you want to make sure you do. Is there another question?
Yes. Can you explain how central obesity in a man is considered an estrogen factory?
Okay, I like that. Okay, so when you develop here, I'll draw the man with central obesity. How's that? And they usually have no butt. So there you go. All right. So okay. So when you gather, there's different kinds of fat in the body. So when you gather the central when you get fat in the organ system, the major driver of that is going to be insulin. So now in your liver, okay, I got to get my pen back out. All right, so I have to do it with my finger. That's fine. All right, so hormones like testosterone are fat soluble. So they actually, once they're used, they have to go into the liver, where the liver makes water out of them. That's phase one, and then it has to bind with something and get out. Goes out mainly through the bile and things like that. But the liver has to convert it to water before you can get rid of it. So if you have too much insulin in the system, what happens is you will promote something that's called aromatization. And aromatization will actually convert testosterone into estrogen metabolites. And those estrogen metabolites, you're not going to get rid of all of them. They're going to go back into the system, and it's going to increase the estrogen in your body. You're going to cry at more movies. Okay, what else? Anything else?
Let's see. How do you combat that central obesity in males?
Very good. You have to go after the insulin resistance. And here again, there's not a this for that on anything. You have to evaluate the patient, look and see what patterns emerge. Let's make it simple and just say, okay, there really wasn't much of a genetic, nobody in their family really had insulin resistance. But you know what? They do eat too many carbs. Number two, they do have inflammation, and maybe they have food sensitivities. They have a tooth, a chronic low-grade tooth infection, or they have a bladder infection, or they have something else that's going on. This could be this. I've seen people on very restricted low-carb diets maintain insulin resistance because they had a chronic infection. It can happen, or they have a poor microbiome. How their bowels move, what's the digestion look like, and all these other things. So you want to look at, these are things you want to look at when you're just looking at insulin resistance to see if any of those patterns. But you can't just stop there. You have to look at all the patterns that possibly emerge. Maybe you find somebody that has burping and belching and bloating immediately after they're eating, and then you think, well, maybe this is low hydrochloric acid. And then you look at the protein and the calcium, and both of them are functionally low. Maybe the chloride's a little low on your CMP, and that would be a pattern showing me low HCl. If you have low HCl, it could be driving a poor microbiome. I'm sorry to talk so fast about this. I'm not trying to really teach that so much. I'm just trying to get the idea that you want to look for patterns. It's all about patterns. But certainly if you have central obesity, here's where you start, and you go through this process and start working it out. Okay, any other questions?
Nope, I don't see any more.
Okay, good. Well, what I'm going to do is, it looks like, and I want to cover the full thing, but I'm going to cover BUN and creatinine. I want to talk about those. I'm not going to speed through this. I'm going to do creatinine and BUN, and then we're going to call it a night. Then next month I will do another one, and then we'll just catch the rest of them. Like I said, I intended to do all of it tonight, but when you start getting on a roll on these things, I just think that all this information is too important just to skip over too fast. So let's go ahead and do this. Let's start here. BUN and creatinine. BUN and creatinine, let's look at a kidney. Here's the kidney. 25% of the blood, the resting heart rate, is actually going to go to the kidneys, and the kidneys are going to filter that blood, and then you're going to have the waste that's going to go through the bladder and out, and then the clean blood goes to the heart, out to circulation. So the kidneys is called the glomerular filtration system. It's a glomerular filtration system. It's made up of a whole series of a bunch of small arteries, okay? So BUN and creatinine should be clearing at a certain rate. So one of the things we use the BUN and creatinine measurements analyze to look for patterns is when both of them are elevated, it's a pretty good indicator that this filtration rate is not as healthy as it should be, and you're not filtering these well, and therefore you have some level of kidney disease going on. So that's kind of the where BUN and creatinine get the press. But let's look a little bit more specifically, because you can learn a lot more from the BUN creatinine than just kidney function. Let's go forward. First off, creatinine is a waste product of muscle metabolism. All right, so let me do a really poor drawing of a muscle here. This is a muscle. So, all right, so how tone is the muscle? We have muscle fibers and they contract. Now, they will contract when, like for instance, when I'm standing or I'm not even moving a muscle, it's going to be at a certain level of tonality. We're always going to have a certain level of tone in the muscle. That tone in the muscle has a lot to do with the amount of protein in the muscle. By the way, let me say this is very important, that the muscle system is the major anabolic driver of the system. It brings vitality. The more tone you have in a muscle, the better you're going to produce testosterone for men and women. The better you're going to produce growth hormone. You know, these kind of it factors that make people live a long time and give them vitality and all that. You have to have protein in the muscles to have strong muscle fibers. Now, I'm not talking about your strength of muscle like you can pick up the end of a couch. I'm talking about that tonality of the muscle. Okay, so creatinine, what is creatinine? When a muscle is doing its normal metabolism, creatinine is going to be the waste product that comes out of that. So in other words, it's kind of like the off-gassing, it's probably not the right word. It's like the exhaust, if you will, from muscles working. So this exhaust is creatinine. Now, we use creatinine, we use creatinine for a lot of different reasons. When creatinine rises and BUN rises, as I said, we think about the possibility of poor kidney function. If you have, this is our number down here, let me see my pen right here. We have creatinine when it is below 0.7 for an adult. It's not the same for children. Children that are like, I think 3 years old, 4 years old, need to have a creatinine at least to 0.4. They need 0.4 and above. Actually, 0.5, I said that wrong, 0.5 and above. For 4 years old and older, 0.5 and above. This is important when you're working with ADHD kids and other kids, because if they have poor muscle, if they have poor protein in the muscles, the brain can only be as strong as the muscles in the kids. By the way, same thing with adults because of the vitality. Let me back up. I don't want to say too many things at once and confuse. When you see a creatinine that is lower than 0.7, what it is an indication is that you have protein loss in your muscles. Now, keep in mind, there are two reasons for protein loss in the muscles. Number one is this. If you have chronic inflammation in your body, here again, you know, it could be food sensitivity, a chronic infection, or whatever the case may be. Whatever's driving inflammation chronically in your body, whatever's doing that, you need to have fuel for that. Now, I want to make sure that this is understood, that when your body has chronic inflammation, the question would be, well, why is your body doing that? It would be better off if it didn't do that. No, actually, the body is going to carry on a long-term inflammation because it sees it as necessary to overcome something else. So it's a natural response. But in order to have this natural response, and by the way, it's not good, it can wear out the system. You have to figure out why it's there. But when you have that chronic inflammation, you need a lot of fuel. Where do you get the fuel? You're going to steal protein from the muscles, and that will give you fuel for that inflammation. So the number one cause for a drop in creatinine and low muscle tone is going to be chronic inflammation. The other is you just have a GI issue and you're not absorbing protein. I guess you could say another one, maybe you're a vegetarian, you're not eating enough protein, or maybe you're just not eating enough protein in your system. But most people are eating enough protein. It's more of a malabsorption issue. So I want you to pay attention to this one. This is a really important functional measurement. And you want to make sure that they stay above 0.7. All right, with a sudden increase, think of a possible urinary tract obstruction of stone. Also, if creatinine goes up very quickly, think of maybe a drug interaction. Somebody started taking a new drug, or there's an infection of some kind, maybe not a UTI, but it could be a UTI. Anything like that, a quick change in creatinine. The good news is that once you have resolved that issue, a lot of times the creatinine will come back to normal. Okay, so creatinine greater than 1.2 in males, think of prostatic hypertrophy. In females, think of possible bladder problems. Now keep in mind that if creatinine and BUN are both up, you have to consider kidney problems as well. All right, so let's talk about blood urea nitrogen. Blood urea nitrogen is the ash of protein metabolism and is produced by protein degradation. Let's look at this. So we have the liver right here, and your body's made of protein. If you look at your system, your bones, your ligaments, your structures, your glands, your tissues, all made of protein. But guess what? Inside of every cell, it's protein that drives the cellular function. Keep in mind, this is very important. We have genetics. You have all of your genetics wrapped up in every cell. But if it's a liver cell, you're only going to do a sliver of those genes that are coding for proteins that make liver function. So what do the genes do? They're just making protein. So protein is everything about life and health. Proteins only last so long. They're going to break down. They go to the liver, and the liver makes new proteins out of them. So in the process, protein, when it breaks down, it is full of amino acids. Amino acids have nitrogen in them. If you leave nitrogen by itself, by its own wares, and you add a little bit of hydrogen, you are going to make ammonia. And ammonia is toxic. The ammonia in the liver is converted to blood urea nitrogen because that is a safer form of nitrogen. So that's what your body's doing. So clinically, we want to see, or functionally, we want to see the BUN 13 to 18. When the BUN goes below 13, it is an indication that your liver is congested. There's one caveat to that. You have to look at patterns. You could have a low BUN, but you have a very low protein in your blood. That would answer it, because if you have low protein in the blood, you're not going to make as much. But if your protein is normal and your BUN is low, you have a congested liver. Okay. Now let's look at some of the other patterns here. If your BUN is high, I'm going to go through this, and then we'll ask for questions, and then we'll close it out for this evening. All right, so if your BUN is high, and remember, we look for patterns. If your BUN is high and your creatinine is high, we think of kidney disease. If your BUN is high and your creatinine is normal or is low, then there are two main reasons for this. Number one, it's either from dehydration, you're dehydrated, or it's inflammation. Inflammation will drive the BUN up. Why is that? I want you to think about this. Because what carries inflammation is protein. Proteins carry inflammation. And if you have a bunch of protein flying around, guess what you're going to be making a lot of? You're going to be making more BUN. So that's going to be the process. So let's read through some of these. There is one thing I want you to be aware of. It's called the sign of 88. What is the sign of 88? Well, let's look and see what the sign of 88 is. The sign of 88 is this. When your BUN goes down to 8, and your protein, normal protein or functional protein, is going to be 7.1 to 7.5. When your protein goes up to 8. So think about that. If your protein in your blood is way up to 8, which generally it's only inflammation does that. Could be dehydration, but it have to be severe dehydration. That's an inflammatory process, usually an infection or something bad like that going on. So when your protein goes up like that, you have so much protein floating around, the liver should be making a ton of BUN. But when your liver is not able to keep up with the demand because you have so much protein that's flying around, you could be having tissue destruction going on. So when you have the sign of 88, it's a serious sign. When you have the sign of 88, you really want to apply your protocols, find out what your patterns are, come back in 2 weeks, maybe 4 weeks, depending on clinically, and you want to check that sign of BUN, sign of 88, and make sure it's getting better. You don't want to just leave a sign of 88 go, because it could be a sign of more serious problems. Now, I will say I've been doing this work for a little while, and I don't remember, I might have had one, but I don't remember a sign of 88 that I saw that we weren't able to turn around. Now, it's not because I'm so great. We just work the patterns. We find patterns and go after things, get, find infections and, get blood sugar going well, make sure that the body's, functioning well, that it has the ability to heal itself. All right, so increased BUN, increased chloride, and increased sodium, think renal problems. Here's just some patterns right here. Increased BUN in the vicinity of 20-25, think of anterior pituitary hepatic destruction. These are mainly inflammatory drivers. You can look at this, but the most common reason for the BUN to go up there is either dehydration or it's going to be inflammation, unless the creatinine is similarly raised. Remember, creatinine should be 0.7 to 1.1, and BUN should be 13 to 18, and they're relative to each other. If I see a BUN, if I see a creatinine at 0.7, I expect to see the BUN at 13. If I see a 1.1 creatinine, I expect the BUN to be around 18. So if I have somebody that's creatinine at 0.7 and BUN at 18, guess what? That BUN's higher relative to the creatinine, even though both of them are in the normal functional range. That still tells me there's inflammation going on there. So we can look at just a couple of cases right here. I'm going just a little long. If you guys don't mind, just give me 5 minutes and I will be finished. Then we'll answer for questions. Okay, so when you look at the blood test, you can see the creatinine and the BUN. The BUN is at 19, the creatinine is at 1. So what they do is they take the creatinine and they give us a calculation, and they give us something called eGFR, which is the estimated glomerular filtration rate. This gives me a percentage of kidney function. So in this person, their kidneys, anytime your kidneys are functioning less than 60%, you are considered to have a grade 3 chronic kidney disease. That's what you're considered at. It could just be kidney disease. Sometimes it could dip there. All right. So, but when you have a GFR, glomerular filtration rate, that's lower than 60, the very next test you want to run is called a 24-hour microalbumin urinalysis, because that will give you an indication of the severity of the kidney problem. So let's look at it this way. In the normal case, we want less than 30 milligrams per gram of microalbumin to show up. So somebody comes in and their GFR is at 59 like this person, and we do the 24-hour catch and they're normal here. What that shows is MR, or they're just at a moderate risk for kidney disease. We're not that concerned about it. Let's take another person. They come in, they have GFR at 50, but yet they scored over 300 here. Then even though they're 50% kidney function, they're at a much more serious situation because they're dumping all kinds of protein, which shows me that filtration system is just messed up. So that's how you evaluate it. Now, if you do a microalbumin and it comes back normal, you don't need to repeat it. But if it comes back abnormal, you will put together a protocol and then you'll repeat it. I'll give an example. Here's a patient that I had that came in. She had 47% kidney function. So, the BUN's 25, creatinine's, so it's all matched. This is kidney dysfunction. So there's other things we could pick, but let's just keep it simple. She had 47% kidney function. Well, I did a microalbumin on her, and this is the number we look at, 206. So she was 206. So let's back up and look at this. She was in this category right here. She was 47%. So she was in this category. So she's high risk. Okay. Now, we did some work, 3 months, whatever that was. We came back and look what happened. Her kidney function went down to 42%. So it was at 47%. It went down to 42%, but I did the microalbumin and look what happened. Instead of 206, it went down to 44. So in reality, her kidney function, or GFR, dropped, but her kidney function is actually getting better. Just needs a little more time. Now, why did it drop? probably because we took her through some detoxification, some other things, it will bounce back. But since I did the microalbumin, I was able to see that she went from 206 down to 44. She's losing less protein, so she's getting healthier there. All right, so I'm going to give you some things to do with kidneys, some protocols, and then we'll call it. Increased BU and creatinine ratio. Think about dehydration and that. Okay, so let me get to a blank page. Okay, so if somebody has low kidney function, and by the way, you're not very often going to see low kidney function and be able to say, aha, I knew it because I saw a pattern there. You're not going to see much of a pattern in the history of the physical exam for low kidney function. It's usually a surprise finding. Somebody comes in, you do the blood work, and their GFR is down to 45 or 52 or something like that, which prompts you to do the microalbumin, the urinalysis. Okay, so what do? Number one thing that bothers the kidneys is going to be circulation. If you have poor circulation, remember, it's the small arteries, a compilation of a bunch of small arteries that really make up this glomerular filtration system. So poor circulation is very important. You want to look to see if they've been chronic users of blood pressure medications, because sometimes what will happen is the kidneys will say, you know what, I need a little higher blood pressure because I need more circulation. And then somebody takes a blood pressure medication, well, they drop the blood pressure, now the kidneys suffer. So in fact, you're going to see kidney dialysis units that are full of people who are on chronic blood pressure medication. So you want to address that, see if you can do something that maybe they wouldn't need the blood pressure medication anymore. Number three, make sure they don't have any infections. Infections, especially things like mold, mycotoxins, Lyme disease, these things have a tendency to drop kidney function. You want to watch out for that. So number four, these people are going to need to exercise. Why? Because they have to increase circulation. Number five, they need to drink water. You need to drink at least half of your body weight in ounces per day. So if you weigh 150 pounds, half of that will be 75. You need at least 75 ounces of water, good water. You can do reverse osmosis, but make sure you supplement with minerals or use Celtic sea salt or something like that. There are actually some good herbs. Cordyceps is a really good herb that cordyceps will help the kidney function. And you just go through the patterns. Make sure your blood sugar is good. Make sure you don't have anemia. If the kidneys are bad, remember erythropoietin comes from the kidneys, and that is what activates your bone marrow to make red blood cells. So you could have kidney disease, and it could be a pattern that is causing anemia. So you put all those things together. Get them some fish oil, do some circulation things, make sure they're moving their body, get the blood sugar going well, make sure there's not infections going on. You want to exercise them, getting them drinking water. Cordyceps is a good herb. I'm certain there's other things that are good out there. Look and see if they have mold issues. These are also things that can really bring the kidney function down. Okay, so these have been some ideas. Dr. Annette, I want to ask if there are any questions.
I do have one. I'm not exactly sure what he means. I just asked him to clarify.
Okay.
But it says, what do you want, W-A-N, by liver support? So maybe he meant mean. What do you mean by liver support? I'm not exactly sure what he was asking there.
Okay. Okay. So yeah, see if he can clarify that, because I want to make sure I'm answering the question that he or she needs. So okay. Well, I really appreciate everybody staying tuned and being part of this. We've had a number of people that have been on. For those who weren't able to attend tonight, I will make this available for 1 week so you can watch it one more time to go through it, because we'll throw some information. And next month, I will just do CMP part 2, and we'll go through the rest of it. And I hope you've gotten a lot out of this. So did we get the question back again there, Dr. Annette?
I don't have a response yet. I'm assuming he just wants to mean what you use for liver support. What do you mean by liver support when you say that?
Okay, so let me just cover that real quick. All right, so keep in mind the most important thing for the liver is really protein. The liver loves protein. So one of the things that I will do is make sure I get them on a good protein shake or an amino acid blend. make sure if you put them on a protein shake, it's not sensitive to it. I always run or try to run food sensitivities because I don't want to put somebody on pea protein and they're sensitive to peas. I don't want to put them on a beef, a bone, broth, and they're sensitive to beef. So, I check food sensitivities and then I go with that. Using amino acids. Amino acids are really good. I love amino acids. If they are insulin resistant and they specifically are not hypoglycemic, then what I'm going to tell them to do is you want to eat a heavier breakfast and lunch, and you want a light supper. As a matter of fact, you're better off if you don't eat meat for supper. If you eat a light supper, you should go to bed slightly hungry. Why is that? Because there's something called autophagy. And what autophagy is that self-eat. That's when the body cleans itself. The brain and the liver will as you rest at night. Unless you have a whole bunch of food in your GI tract, then your liver is dealing with all that food you ate. If you ate a big steak, or you ate something that's hard to digest, or you ate something an hour before you went to bed, you're laying there and your liver's not able to clean itself. It's just simply has to deal with the food you ate. Keep in mind, we talk about how do you detox the liver? Well, guess what? The liver is designed to detox itself. So give it some protein, give it amino acids, cut your carbs down, low carb diet, and go to bed slightly hungry. And these are all good routines. Certainly, you can use things like liposomal glutathione. You can use L-glutamine. You can use various detox formulas from vendors and so on and so forth. I'm not against those. I don't use them a lot, but I'm not against those. Those will do okay. I just try to get the problem resolved without having to do that in the average case. So use a protein. Make sure the north to south digestion is going well. So meaning that make sure that they have enough HCl. Make sure they have good enzyme support, pancreatic enzyme support. Make sure that the bile is flowing well, and do these things, and you'll do very, very well. And let me just say one more thing. If you have low HCl, you're going to have burping, belching, bloating, offensive breath, things like this. Enzymes, if you don't know, just give them some enzymes when you're going through the first part. Look for things for bile flow if they've had, if they can't tolerate fatty or greasy foods, and ask them. Sometimes they'll put on there that fatty foods don't bother them, but then you ask them, hey, did fatty foods bother you? Oh, I never touch them. Well, they say they don't bother them because they never touch them. So if somebody has a problem with fatty or greasy foods, they have a bile problem. Keep in mind, insulin resistance, estrogen dominance, and a low functioning thyroid are all things that can slow that bile function down. So these are the things you want to pay attention to. Get your digestion going right and feed that liver, and do it that way. I don't like to just simply give people nutrition, because you can't nutrition yourself out of a poor diet and a poor lifestyle. You have to get those things right for long-term health and longevity. Okay, any other questions? Okay, very good. Well, I appreciate everybody being here, and thank you for being a part of this, and join along and tell other people to join along with us.